Thanks so much for joining us today. My name is Mike Ruma. I'm a maternal fetal medicine specialist, and I'm here to talk to you today about evaluating the patient with symptoms of preterm labor. And we're going to talk about what we get right and where we go wrong. First and foremost, I am a private practice maternal fetal medicine specialist. I work for a large perinatal practice in the state of New Mexico. I also have a lot of fun working with a variety of different companies, Hologic, CCSI, and Philips Ultrasound. I work with these companies because I believe in what they produce, and I think that we as clinicians have an obligation to work in collaboration with industry to really bring products to help patients each and every day, the products that we need to take the best care of patients. Today, we're going to go over a variety of topics. I'd like to introduce the use of protocols and standards and how we use those to achieve the absolute best outcomes for patients. Then we're going to go over a variety of research surrounding fetal fibronectin, transvaginal ultrasound, and how we might go about using those specific tools in the assessment of preterm labor. We'll talk a bit about the effect of these protocols actually on the patients that present with symptoms of preterm labor, explore the causality of preterm birth, and then ideally I want to detail how you should go about screening these patients, discuss some of the etiologies like sexually transmitted infections. And my absolute hope is that today we motivate you to assess what you're doing in your own institutions, your own organizations, offices, hospitals, residency programs, nursing scenarios, what you're doing at your own institution and how you might make a better impact on patients with preterm labor. A bit about preterm birth. This is an issue that is incredibly important to each and every one of us that practices in obstetrics today. Annually, we have just shy of 4 million births in the United States. We have great job security in what we do each and every day, taking care of pregnant women in the United States. As a high-risk pregnancy physician, we also have security in the fact that we're going to deal with preterm birth each and every day that we show up at work. On average, 10% of pregnant women deliver preterm. And as you see in this graph from the March of Dimes, we've had a decreasing rate over time through some of the significant efforts in research that have been brought to bear to help pregnant women with symptoms of preterm labor, with a history of preterm birth, prevention of preeclampsia, etc. You can see though in this graph that we've had some difficulties in the last few years. Consecutively, 2016, 17, 18, and into 19, we have this rate and it's rising. I'll show you this map from the March of Dimes because preterm birth is not isolated to one area in the United States. It occurs in absolutely every state in the country and is a major issue. Roberto Romero says preterm delivery has been and remains the most important challenge to modern obstetrics today. Dr. Romero is a well-respected researcher, maternal fetal medicine specialist, and a leader in our field in the United States on this topic. If he's telling us this is a major issue, it's certainly something that we need to be introspective upon in our own practices today. I'd like to share with you a bit of a story from a wonderful book by Atul Gawande. Dr. Gawande is a Harvard general surgeon. He has written numerous New York Times bestsellers. This book, Checklist Manifesto, I read several years ago, and it really changed my approach to medicine and how I approach patients and how I organize my office and my systematic care. But this is a B-17 Flying Fortress, and I'd like to take a moment to tell you a bit of a story from Atul Gawande's Checklist Manifesto. So on a day in 1935, a group of military, brass, manufacturing executives from a variety of aircraft manufacturers came to Dayton, Ohio for a competition of sorts to really see who was going to bring the next military long-range bomber to bear for the United States military. And Boeing provided this plane. And on this day in 1935, a variety of U.S. servicemen ran out to this aircraft, 4 engines rumbling, and they took off, reached to about 300 feet, banked, and then stalled and crashed in a fiery explosion. This was a catastrophe for Boeing. 2 U.S. servicemen died in this incident. There was a lot of investigation as to the causality of this accident, and people said, well, this aircraft was simply too complicated to fly. Well, ultimately, what they identified in this accident is that it was simply human air. And all the anxiety of showing off the capacity of this brand new aircraft, those pilots forgot to remove 2 metallic clips from the flaps. When we face catastrophe, we have to come together and think about, how can we approach that issue in a better fashion? And in this day, Boeing knew this plane was very, very, very complicated. How do they make a complicated process simple? And how do they achieve ideal outcomes? And what they came up with was something called a pre-flight checklist. In this pre-flight checklist, it says, use the checklist in your aircraft. Do not rely on your memory. You may forget something. Our human minds are not adept at remembering significantly large number of things, and under anxiety and under excitement, we often forget them. This pre-flight checklist was so important in 1935 that it led to Boeing's selling hundreds of these B-17 Flying Fortresses. It became the most successful plane in all of aviation history, flying 2 million sorties, and ultimately never have another episode of human error. We as physicians, nurses, midwives, resident doctors, we have a lot of tools, just like a cockpit has a lot of different things that we have to assess and evaluate when we look at patients. And in regards to preterm labor, we can talk to patients about their history. Have they had a prior spontaneous preterm birth? Maybe that patient's delivered at 25 weeks before, had just preterm labor, and then unfortunately her baby spent 10 to 12 weeks in the neonatal intensive care unit. So that history is ever so important, talking to the patient. We can assess their symptoms. Maybe she has contractions, maybe she's bleeding vaginally. We need to always do a physical examination, assess the cervical dilation. And then we have a couple different tools as well that we can lean on that I would like to talk to you about next, and that's fetal fibronectin testing and cervical length assessment by ultrasound. Why are each and every one of these tools so important? So ultimately the reason is that when people present and are hospitalized for preterm labor, less than 50% of them actually are going to deliver preterm. That means that over half of them deliver at term. And within a shorter period of time, less than 10% of them are actually going to deliver within a week. This is a slide just demonstrating to you the relative risk of spontaneous preterm birth at less than 32 weeks. I know as obstetricians we love contractions. They're very concerning. They're disconcerting to moms. They cause anxiety. I'm contracting. This slide demonstrates to you that uterine contraction activity during pregnancy, really and particularly preterm, is a really, really poor indicator of a preterm birth. For that patient that had vaginal bleeding, that's a higher risk actually of her delivering preterm less than 32 weeks. If she just has a simple history in a prior pregnancy where she delivered preterm in her past pregnancy, that's a remarkable risk factor. And then if you have a short cervix on vaginal ultrasound, again, incrementally rising risks. But if she has a positive fetal fibronectin test, she has a markedly higher risk of preterm birth, 14-fold higher than when she walked in the door to see you in an OB triage. When we're working on labor and delivery at 2 in the morning, we don't really want predictability less than 32 weeks. We want to know, is the patient going to deliver within a week? Do we need to do something to that patient? Do we need to admit her to the hospital and provide interventions, or can we safely and confidently discharge that patient? In this slide, you can see the negative predictive value in dark blue and the positive predictive value in light blue. And we've been informed by societal guidelines that really we shouldn't use either test alone, but ultimately that tests work best in unison. And you can see at the top that when we have an abnormal cervical length and a positive fetal fibronectin, the positive predictive value is substantially higher. And in a study by Gomez, we know that the positive predictive value can be improved by 50% for spontaneous preterm birth by simply using both an abnormal cervical length and a positive fibronectin together. When we look at patients, we have a whole host of factors and demographics that place them at a higher risk of preterm birth. As I told you before, that prior history of spontaneous preterm birth is incredibly important. If a patient has twins or triplets, we know those patients are at a markedly higher risk of preterm birth. If they have a history of cervical insufficiency, first trimester or second trimester vaginal bleeding, all of these things add up as risk factors for that particular patient, and we need to take all of that into our mind to make a clinical assessment. In addition to clinical history and prior spontaneous preterm birth, we often pay a lot of attention to cervical dilation. The most important point is that we often think that patients are at risk because they maybe are 1 centimeter dilated or 2 centimeters dilated, but actually that's not a very significant and pertinent marker to predict whether or not she's going to deliver within a short period of time. Between 0 and 1 centimeters dilated, to deliver within a week, only about 16% of those patients are going to deliver. And when they're 2 centimeters dilated, only about a third of those patients are going to deliver within a week's time frame. Additionally, we all, as obstetricians, I think have a reasonable understanding that our assessment of cervical dilation varies. And we can see this in charts. When I am consulted on a patient that has preterm labor symptoms, go to review her chart, she may have gone from 1 centimeter, 0 centimeters, to 2 centimeters, to 1 centimeter, all varying by the individual who's doing the cervical evaluation. And in this study, 52% of providers reported different dilation measurements actually on identical simulations. So we need to be aware that there is significant variance between ourselves as well as in between individuals, giving us credence to rely more on objective laboratory testing and ultrasound data. As a maternal fetal medicine specialist, we do a tremendous amount of ultrasound. We lean on cervical lengths in their evaluation, but we really need to know how to do a cervical length effectively and well. And this organization, Cervical Length Evaluation and Review, part of the Perinatal Quality Foundation of the Society for Maternal Fetal Medicine, is there to help you learn best how to do this measurement. And we really need to go through the process in order to train ourselves as to how to perform a cervical length by vaginal ultrasound correctly. NIH funded very large respected studies on the topic of preterm birth. When they assessed cervical length by vaginal ultrasound, a really large number of those images acquired were not correct. Take, for example, the SCAN trial. 15% of reviewed images of vaginal ultrasound cervical length were not accurately measured. And when we look at the times it takes for sonographers, MFM fellows, MFMs, OBs, we also, when submitting images for review at this organization, we often need to retake the test. We need to learn better how to predict preterm birth using this tool, vaginal ultrasound, and the cervical length. It's something that may be available to you. I'd really encourage any institution to make certain that all individuals that are doing vaginal ultrasound obtain certification through CLEAR so that they can provide the best and highest quality measurements and prediction of the risk of preterm birth in that setting. First and foremost, always should be done transvaginally. Why? It puts the camera at the closest point of the object of interest, which is the cervix. And similar to a nuchal translucency, that picture of the cervix should be enlarged, should take up about 3/4 of the screen. You want to make sure that the anterior width and the posterior width of the cervix are similarly sized. The bladder from the mom should be empty. We don't want any additional pressure on that cervix. It could alter and maybe give us a fictitious measurement, so the bladder should be empty. Make sure that you can see the internal cervical os and the external cervical os clearly. And we should be able to see the entire canal with very, very good visibility. Make sure you also put your calipers on the correct places. We don't want to measure the head, we don't want to measure the vagina, we want to measure the internal cervical os to the external cervical os. That is the cervical length. And then we want to ask you to make sure you assess and consider something called mobility of the cervix. And if I'd ask you, how long do you take to do a vaginal ultrasound? And many of you would raise your hand and say, 10 seconds, maybe a minute. But actually, you'd all be wrong if that's what you were to tell me, because ultimately you should be taking about 3 to 5 minutes looking at the cervix to assess, is it going to shorten? Because it may start at a normal measurement, but ultimately it may get shorter. Why 3 to 5 minutes? What could be going on? Why is that patient actually in front of you in obstetric triage? It's because she is contracting. And uterine contractions tend to come every 1 to 3 minutes. So we need to allow sufficient time for her to have a contraction and potentially shorten that cervix, because it's the shortest, best cervical length. That's the measurement that we want to include. Why is this so important? I'll give you an example. Here's a cervical length, and I can tell you this looks great. A cervix that's curved almost always going to be perfectly normal. And if you look at the measurement, it's greater than 2.5 centimeters, and this is a perfect normal cervical length. And I'm going to wait till minute 1, minute 2, minute 3, and then this is what you see. If we didn't wait, we wouldn't identify that there's something significantly wrong with this patient. Now at minute 3, she has a U-shaped funnel. You can see that that residual cervical length is now markedly shorter. And this is the shortest best measurement, which should be recorded, should be reported, and should be used to predict her inherent risk of spontaneous preterm birth. If we didn't wait, if we didn't know, if we didn't take a class on how to educate ourselves best to do cervical length evaluation through CLEAR, becoming accredited to do cervical lengths, we may miss this and miss the opportunity to actually provide appropriate and excellent care to this patient. We also have an objective tool called Fetal Fibronectin. Fetal Fibronectin was designed as a test to act as a rule-out test. Its negative predictive value, which is 99% for delivery within 14 days, is truly the most significant beneficial aspect of the test. It helps us to take that scenario, a patient with symptoms of preterm labor, who many of them are not going to deliver preterm. It can give us objective evidence to allow us to confidently and safely discharge the patient without any intervention. Fetal fibronectin, FFN, is a glycoprotein. It's found between the amnion, or the sac, and the chorion, the layer that adheres to the uterus, and it's a bridge. We say it's like a glue. It holds the pregnancy inside. And between 16 weeks to about 35 weeks, this protein should not be identified in the vagina. And so when you do a fetal fibronectin test and you collect a swab from the posterior fornix with a Dacron-coated swab, and that test is actually positive at, say, 25 weeks, 28 weeks, 32 weeks, now we have an abnormality, and we have a positive lab test that's actually telling us something significantly is unique with this patient. We have an FDA approval for FFN testing. If the patient presents with symptoms of preterm labor, it can be done between 24 weeks and 0 days to 34 weeks and 6 days. And we also have an asymptomatic FDA indication from 22 weeks to 30 weeks and 6 days. It's really important to pay attention to that symptomatic patient and the 24-week and 0-day to 34-week and 6-day window. Why? Most preterm births actually occur between 32 to 36 weeks. So what we call late preterm births. And a recent statistic from the CDC says that that number is around 80%. So those are really the folks that we should be paying attention to. Late preterm birth is a major issue in our country. And there's been a recent trial by Cynthia Giamfi-Bannerman, the ALPS trial published in the New England Journal of Medicine, Antenatal Late Preterm Steroids, that really should give us some credence to paying a lot more attention to that cutoff of 34 weeks and 6 days. Most preterm births are in the late preterm setting. Uterine contractions are not very predictive. Bleeding is not very predictive. Cervical length after 32 weeks is also not very predictive because most women are going to have a short cervix at that gestational age. So we should be using this objective biochemical test, fetal fibronectin. It's going to be negative in 80% of patients, positive in 20%. And that positive, I told you, increases their risk 14-fold for preterm birth. And maybe we should give that pregnant patient antenatal corticosteroids for the benefit of the preterm fetus. Pay attention to the most recent literature and listen to that objective test in the late preterm setting. Fetal fibronectin is primarily used for its negative predictive value. We know that if that test is negative, 99% of patients are not going to deliver within the next 14 days. And this negative fibronectin result gives us objective evidence to utilize to confidently discharge that patient, send her home, provide her with obstetric precautions, and a high level of confidence that she's not going to deliver in the next 2 weeks. The test also has a positive predictive value, which predicts an elevated risk for preterm birth if the test is positive. If the patient receives a positive result, That result indicates that she has a markedly higher risk of delivery in the next 14 days, upwards of 16%, and distinctly predicts a higher risk of delivering preterm less than 37 weeks in almost 45% of cases. As you can see, the tool fetal fibronectin, primarily utilized for its negative predictive value, also has predictive benefits when positive as well, identifying that patient at risk of spontaneous preterm birth and who may benefit from many of the interventions that help her unborn child. Fetal fibronectin is a tool that should be collected using a speculum. You place the Dacron-coated swab in the posterior fornix. It stays there for 10 seconds to absorb some of the vaginal secretions. Within the vaginal secretions, if fetal fibronectin is present, that is what we're going to detect. You take that swab, you place it into the tube, you snap the little plastic stylet and put the lid on the tube, aligning the tube so nothing spills out. It's not the swab that we're testing, it's the liquid buffer that we're testing. That's where the fibronectin and actually the material for the lab test is found. So very important not to spill the liquid within the vial. So we've gone over how to collect a fetal fibronectin. I think it's also important for you to know that it takes less than 30 minutes to run this test. And each of your organizations ideally needs to develop a mechanism to get the specimen from labor and delivery to the laboratory and then have a result called directly so that that test has an impact on the evaluation of the patient. So FDA provides an indication for patients that present with symptoms of preterm labor, again, from 24 weeks and 0 days to 34 weeks and 6 days. And I told you earlier the importance of that late window at 34 weeks and 6 days. This test should be collected prior to any manipulation of the cervix. So we need to do and collect the fetal fibronectin before the cervix has been evaluated with a digital exam. Because if we do an examination and the patient is found to be 1 centimeter dilated, simply by placing and conducting a digital exam, we may actually release fibronectin and cause a false positive test result. Ideally, we need to avoid running the test if there's evidence of moderate or gross vaginal bleeding. So if the swab is any more than a light pink color, it's not that the test cannot be run, it's just that blood may cause a false positive test because blood has a protein called fibronectin in it as well. We're not going to do this test after 3 centimeters and beyond, so 0, 1, and 2 centimeters dilation. Again, why is it so important to use this objective tool? Because that's where we really have very little predictability from that cervical exam. The test should not be used if you suspect rupture of membranes, and then ideally trying not to place the Dacron-coated swab directly into, say, vaginal progesterone, which may be present within the posterior fornix, or any other type of cream in the vagina. The swab needs to be able to collect vaginal secretions and absorb the fibronectin to provide an accurate result. If a patient has had sex prior to an evaluation and triage, you can still collect a fetal fibronectin test. If the test is negative, it's just as valid whether or not the patient has had sex or not. Fetal fibronectin is often also found in sperm, and it's not fetal fibronectin, it's just another form of fibronectin. And so semen can provide additionally another false positive result similar to vaginal bleeding that's significant. The specimen can be held at room temperature for 8 hours. It also can be refrigerated for 3 days. Fetal fibronectin testing is freely available. The collection kits are free to organizations, and in my experience and within my practice, this specific type of testing has been well covered by insurance carriers. All of the things that we've been talking about, the tools that we use, the ultrasound, the fetal fibronectin lab test, our cervical exam, all of these evaluations lead to different types of interventions. What are some of the things that we can do to the patient? We can transfer to an appropriate level NICU. This happens a lot in my state in New Mexico. We're the 5th largest state in the United States. Very broad landmass and really rural as you leave Albuquerque, the biggest city in the state. We often have to identify patients that are at risk in rural locations and transfer them to a higher level of care so that infant can get the absolute best care. We all know about this compound called antenatal corticosteroids. It helps protect against respiratory distress syndrome. Potentially the most important medication ever in the history of maternal fetal medicine, and something that we need to appropriately time. And then magnesium sulfate, additionally, another medication that provides tremendous benefit in protecting unborn children from cerebral palsy. Each and every one of these interventions has a cost. To transport a patient by air, particularly by helicopter transport, in 2020 this costs over $36,000. And if we admit the patient to the hospital, on average a hospitalization costs over $4,000. What if we don't intervene correctly? What if we don't identify that patient in a rural location who needs to come to a higher level of care, a bigger hospital, a hospital with a neonatal intensive care unit? This is a study out of Canada that demonstrates that we have significantly improved outcomes for preterm infants if they're born in a large tertiary hospital. The Inborn versus Outborn indicates Outborn, small rural hospital, Inborn, large tertiary level facility, facilities that I work in on a regular basis. If we identify that patient who has symptoms of preterm labor, transport her to a higher level of care, appropriately identifying things that are unusual with her, the infant has a much better chance at survival. Inborn, 9%, outborn, 16%. The death rate is twice as high in a small hospital as it is in a tertiary level facility. And our complication rates are also markedly higher if the infant is born in a small hospital versus a large tertiary medical center. So just demonstrating to you the critical importance of identifying those patients that truly need transfer to a higher level of care. In our state in New Mexico, there's really only one city that has significant access to neonatal intensive care units. These NICUs are not identified in every single city throughout the United States, and if we over-transport patients, don't use our resources accurately, we may be transferring patients significantly unnecessary, hundreds and thousands of patients that are not actually in preterm labor. This strains our limited resources, wastes hospital beds, wastes resources, and ultimately is not the approach that we should have for these patients. Aside from getting patients to tertiary level facilities, other interventions include antenatal corticosteroids, and we should look to our professional societies, the American College of Obstetricians and Gynecologists, for guidance here. It is critically important, and it is recommended that any patient in preterm labor where delivery is anticipated between 24 and 34 weeks, those individuals deserve and require administration a single course of steroids. And if they show up later, 7 days after that course, they should be receiving a repeat course of steroids as well. Betamethasone and dexamethasone are the medications most available in the United States. Betamethasone has slight superiority, and we utilize that medicine preferentially because it conveys a lower neonatal death rate than dexamethasone. The doses for betamethasone should be 12 milligrams. It is given IM for 24 hours apart in 2 doses. Dexamethasone, 6 milligrams, Q12 hours for 4 doses. Why do steroids matter? Steroids are so critically important to the benefit of that unborn baby. It helps markedly reduce their neonatal death rate, it decreases respiratory distress syndrome, it decreases necrotizing enterocolitis and systemic infections in the neonate. Antenatal corticosteroids, again, as I mentioned before, the most important intervention. Use FFN testing and cervical length evaluation to identify those patients that are going to benefit the most and really deserve antenatal corticosteroids for the benefit of that preterm baby. How are we doing with giving antenatal corticosteroids? Here's a study from Razaz that demonstrates that we really are not doing a wonderful job in timing the administration of antenatal corticosteroids. What does it mean? We want to give steroids and that dosing so that the fetus is born within 7 days, because if the mom has gotten that medication and time passes greater than 7 days, the benefits wane significantly. In this study, only 20% of patients actually received optimal timing of the antenatal corticosteroids. We need to do a better job. And the reason I'm going to say that we need to do a better job is that we're not using the tools that we have in our own institutions. Over time, if we don't time antenatal corticosteroids efficiently, the benefit wanes big time. Respiratory distress syndrome at 8 to 14 days is 2.7 times higher, and if we get beyond 14 plus days, that rate is 6-fold higher for respiratory distress syndrome, which is ultimately one of the major issues for preterm infants. ACOG also wants us to make sure that we administer magnesium sulfate, and evidence supports from a variety of studies that magnesium sulfate protects the fetal brain. Ideally, this medication should be administered to all patients with symptoms of preterm labor where delivery is anticipated less than 32 weeks. In studies, it's most beneficial to fetuses less than 28 weeks, but this is an incredibly important medication, similar to antenatal corticosteroids. Incredibly important that all institutions, labor and delivery units, residency programs, etc., develop protocols and guidelines so that we know who is going to benefit most from magnesium sulfate to help prevent cerebral palsy in those infants. I've talked to you about a lot of things today. I've talked to you about how to evaluate patients with symptoms of preterm labor, the tools that we have in our facilities. I've talked to you about the pros and cons of interventions, the cost of not intervening, the cost of intervening. Why are we talking about this today? The reason is that today in the United States, we don't truly have a standard of care for these patients. Why is that? If you were in the audience today and I was speaking to you directly, I'd ask you, what are you doing in your own institution? And my bet is that you tell me that it varies. On Monday, we do it this way. When this doctor's on call, we do it this way. That's not a great approach, right? I told you about the pilots. They follow this pre-flight checklist. It assures good outcomes, safety. In medicine, we often have a haphazard approach. Why do we accept this haphazard approach? I mean, what causes it? Well, we're pretty haphazard in medicine because we all think that we're smarter than each other. We have this thing called autonomy of providers. You have the older doctor talking down to the younger doctor, telling them about his or her prior experience and how great it was then. And we all think that we're smarter, and we all are going to do what we all want. That's called autonomy. We have really little oversight and enforcement in medicine as well. We take a board exam, we get licensed, and then we do continuing medical education each and every year. But if you make a mistake, who's going to call you out on that mistake? In most circumstances, when you leave residency training, when you leave a fellowship program, there's really, really little oversight. We also have different training and experience. Train in the East Coast, train on the West Coast, learn different processes. But ultimately, that also leads to this very haphazard approach to medical care. And then we have different levels of concern. Sometimes we run to the bedside, sometimes we walk casually. Sometimes things strike us as very concerning, sometimes they don't. And there are doctors that are very concerned, and there are doctors that are not so concerned. And this also causes a haphazard approach. And then, unfortunately, sometimes our research is conflicting. We read some studies that are supportive, we have some studies that argue a contra or an opposite point, and that conflicting research leads to a lack of standard of care. Our professional society, the American College of OB/GYN, wants us to do a better job. They're calling us in this committee opinion, telling us that protocols and checklists reduce patient harm. By doing things in the same fashion each and every way, that leads to a markedly better outcome and safer patient care. When we develop protocols in any institution, we want to get a lot of stakeholders involved. We want to educate people on what the protocol is, train them on what is new, and then ideally do quality review to assess, are we doing a better job each and every day in taking care of patients? What would be some of the benefits if we actually implemented a protocol within our own institution? If we followed a specific path, the patient shows up with symptoms of preterm labor and we do X, Y, and Z. If we followed that pathway and at the end it says negative evaluation, does that actually yield benefits? Could we decrease maternal admissions? Could we maybe decrease the length of stay in hospitals? Could we avoid having to fire up that helicopter and spend all that money unnecessarily? And then if the evaluation's positive, could we actually target intervention to the highest risk patient, and maybe there would be a benefit to her? This is a study, one of my favorite studies by Rose, performed at the Mayo Clinic, Cost-Effective Standardization of Preterm Labor Evaluation. This study was done in a residency program. At the Mayo Clinic, they developed a protocol for assessment of patients with symptoms of preterm labor. They said, let's try something new. Let's not do a haphazard approach. Let's try a protocol, a systematic way to be efficient and evaluate patients each and every time the same way. And so patients came in, they got evaluated with their symptoms of preterm labor, a fetal fibronectin test was acquired and sent to the laboratory, and we performed vaginal ultrasound for cervical length testing. If the evaluation was negative, the patient was discharged home with precautions. If the patient was considered to have a positive evaluation, that patient was admitted to the hospital for magnesium sulfate and antenatal corticosteroids. So at the Mayo Clinic, they evaluated over 200 patients, and they wanted to know how well did that protocol perform. And they found that the negative predictive value was 99% for delivery within 7 days and 97.8% with delivery less than 14 days. What's this telling you? It's telling you that if you trust the protocol you develop, utilize the tools at the bedside, fetal fibronectin testing, vaginal ultrasound, assess the patient with a good clinical history, you're not going to make a mistake. When the protocol says negative, trust the protocol because those patients are not going to deliver within a 14-day time frame. They also found that the protocol affected their admission rate. They decreased their admission rate by over 50%, 15 admissions to labor and delivery versus 34 admissions the preceding year. I don't know about you in the audience. I round on patients each and every day in the hospital. I mean, maybe it's great to round on 5, 6, 7 patients, but do you really like to round on 10, 15, 20 patients a day, seeing patients that are admitted unnecessarily that don't truly need to be there? You can use a protocol, decrease your maternal admissions rate, have a great negative predictive value, and also save money. They found that this significantly saved money within their own organization, and this protocol became a formal policy at the Mayo Clinic. As I told you previously, there are about 4 million births each year in the United States, and if this protocol was applied nationally, they estimated that we would save about $500 million in wasted expenditures simply for admitting pregnant women unnecessarily. I'd like to tell you about another study. This is one of my favorite studies by Amen Ness. Does knowledge of cervical length and fetal fibronectin affect the management of women with threatened preterm labor, a randomized trial? In this study at Thomas Jefferson University, they also implemented a protocol very similar to the previous protocol at the Mayo Clinic. They looked at patients between 24 weeks and 0 days to 33 weeks and 6 days, and they managed them specifically according to the protocol you see here. What they found in this study and what they were after was, could they improve the time of triage? Could they get patients into triage and out of triage in a more efficient fashion, save time by following a specific protocol for preterm labor assessment? And this was actually a randomized controlled trial, a little different than the prospective study previously performed at the Mayo Clinic. They had 100 women, 50 in the protocol group and 50 in a standard management group. And ultimately, their primary outcome, as I told you, was to evaluate time from initial evaluation to discharge. And they did see a slight decrease by using a protocol in the time, but it actually wasn't statistically significant. So ultimately, this study, the primary outcome shows no utility to the protocol, but it did save a certain amount of time. 25 minutes is still pertinent. But I talked to you a little bit and point out this secondary outcome. Maybe I told you previously, if we focused our attention to those people that have a short cervix, a positive fibronectin, that are contracting, that are symptomatic, maybe if we actually focused magnesium sulfate, antenatal corticosteroids to that specific group, maybe we could actually have a benefit to the patient. And in Ness's study, they actually saw an unanticipated outcome. They saw that the preterm birth rate was less in the group that was evaluated using a protocol versus the women that were randomly assessed in an unprotocolized fashion. They had a markedly higher preterm birth rate. The relative risk was 0.37. That means that there was a 63% improvement in the risk of spontaneous preterm birth less than 37 weeks simply by following a protocol. They didn't know why they saw this in the study, but this has always lingered with me and I think is a major impetus for why we should be paying attention to protocols, because it actually may benefit that patient with symptoms of preterm labor. This slide simply graphically shows you that in the patients that went through the protocol, 6 out of 46 of them had a spontaneous preterm birth, or 13%, versus the standard blinded group that went through a non-protocol setting, random haphazard approach, and they had a 36% preterm birth rate, less than 37 weeks. The takeaway, potentially protocols may actually help prevent spontaneous preterm birth in patients that present with symptoms of preterm labor. This study is the only randomized controlled trial to date that uses a protocol, and while it didn't show a benefit in time, it did show a significant reduction in the incidence of spontaneous preterm birth in the knowledge group compared to the standard blinded group. As always, the authors in this study said that these findings require further study in larger randomized trials. And I'd really encourage one of you listening to me today, we need an individual to make this effort and repeat this study. I'd be happy to help you. It'd be a tremendous benefit to pregnant women that present with symptoms of preterm labor to really answer this question and show, does a protocol positively benefit women by reducing their risk and reducing their actual rate of spontaneous preterm birth? What I think is important today, each of our institutions is really different. We have institutions that may have availability of vaginal ultrasound. We may have facilities that have availability of fetal fibronectin. Some of them may have both. Are these things in your facilities? Are they available 24 hours a day, 7 days a week? Do you have people that are trained, certified by CLEAR to actually perform all of the cervical links that you need to have done? Here's a protocol that I really like, and it incorporates the evaluation, our physical examination, and then our management. The takeaway on this algorithm is that we don't always have all of our tools available 24 hours a day, 7 days a week. Vaginal ultrasound, as I told you before, requires unique and special training. And maybe your institution doesn't have a CLEAR certified person that's available to do that vaginal ultrasound. And so if it's unavailable, I'd recommend that you complete fetal fibronectin testing and utilize the positive and negative results of the fibronectin test to direct your management. The negative predictive value, as I told you earlier, has a tremendous benefit to rule out preterm birth. 99% of patients are not going to deliver within 14 days. So simply a fetal fibronectin test that's negative can be utilized to provide management. Discharge that patient confidently and safely from the hospital. And if the test is positive, utilize that test to provide some interventions that have known benefit to the unborn child. This topic of preterm birth evaluation is really no small subject, and people will say there's no literature out there to guide how we should manage patients with symptoms of preterm labor, but I'm going to argue that there really is a lot of research on this topic. Here's a PubMed evaluation using keywords fetal fibronectin. You can see there's over 2,000 studies on this topic. And if I put fetal fibronectin with the words preterm labor, there's over 500 studies available in PubMed. This is not an understudied area. There are numerous more that you can research on your own that give substantive evidence to why we need to be utilizing each and every one of these tools. Just to give you a sample of some of these studies, this is a systematic review looking at a variety of different studies just using fetal fibronectin. Did it impact admissions and length of stay? If you look at that column on the right-hand side, you see statistically significant, 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 p-values that are all significant. And all of the studies highlighted in red identifying a negative fibronectin showed to us that there's a decreased amount of moms that need to be admitted to the hospital, and they also had a decreased length of stay. This is an incredibly important study by Sean Blackwell, former president of the Society of Maternal-Fetal Medicine. It was a study of a national insurance claims database that looked at over 23,000 women who presented with symptoms of preterm labor. In this study, 24% of those patients were admitted, but interestingly, another 76% of them were discharged home. In this study, of those 3/4 of patients that were discharged home, 80% of them went on to deliver greater than 3 days later in their pregnancies. But the most important aspect of this study, what's so striking in this study, is that 1 in 5 returns to the hospital within 72 hours of their own discharge and delivers preterm. In this study, if you take it a step further, how were those patients that actually delivered preterm within 3 days of their first evaluation and triage, how were they actually evaluated? You can see in this pie graph that almost 80% of those individuals received no objective evaluation, no fetal fibronectin laboratory test, no transvaginal ultrasound for cervical length. Literally nothing was done to evaluate in an objective fashion that patient's inherent risk for preterm birth. You can see that 18% of them had a cervical length, 3% of them had only fetal fibronectin, and only 1% had both of those important tools for the evaluation of patients with symptoms of preterm labor. This study is something that should be striking to anyone that practices obstetrics. We know that patients that present with symptoms of preterm labor, that's the most common triage visit, and we need to do a better job. This study clearly points out that we have significant room for improvement in how to thoroughly and completely evaluate the patient who presents with symptoms of preterm labor. There are a variety of pathways to preterm birth. There's inflammation, there's stress in pregnancy that can activate the maternal fetal hypopituitary axis, there's pathologic uterine distension with twins, there's infection, etc. And I'd like to talk to you a little bit more about some of these pathways. And we know that sexually transmitted infection truly is a bad actor in pregnancy. It can cause preterm labor and preterm birth. It can cause rupture of membranes. It can lead to intrauterine growth restriction, infection in utero, and harm to that actual unborn baby. And we need to appropriately screen women for STIs during pregnancy. In the United States today, we have a rising rate of chlamydia and gonorrhea. You can see in this slide that these rates have increased by almost 20% and 60%, and we need to pay critical attention to them because they are a major contributor to preterm birth. In the United States, we should be screening at the first prenatal visit nearly all patients for chlamydia and gonorrhea. And if they're positive, they need a repeat test because often that infection comes back. And a positive test, having a chlamydial infection or a gonorrhea infection, ultimately can be harmful and yield more preterm births, all of which we want to avoid. In conclusion, I've shown you a variety of studies today, a lot of evidence that really support the use of fetal fibronectin testing and cervical length for the evaluation of the patient with symptoms of preterm labor. I've also demonstrated to you that by following a standardized protocol, we can actually affect outcomes. We can decrease hospitalizations, we can reduce unnecessary healthcare expenditures, and we might actually, by following a specific preterm labor evaluation protocol, reduce the risk of spontaneous preterm birth in those patients. As always, future research is going to direct the development and refinement of these protocols, but there's a lot that we can do today, and we should be paying attention to that. I started with Dr. Gawande, and I'd like to end with Dr. Gawande. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists, but we often pay little attention on how to put them together and make them fit well. We need to do a better job, and I hope I've shown you that there is a critical issue with the evaluation of pregnant women. The number one reason that patients present to triage in the United States symptoms of preterm labor. We need, and these women deserve, a much better and more thorough evaluation. Thank you very much for watching today. I appreciate your attention. I'd be happy to answer any questions. Please feel free to reach out to me.